Morning. Can you hear me with this? No, because it's not on. Can you hear me without it? Oh, let's not use it then. You need it? Okay. Can you hear me now? Can you hear me? Oh, there it is. All right. Good morning. Thank you for coming. I know the weather is not great. The roads are not great, so I really appreciate you coming. During registration, I noticed about 1/3 of you are from the community, and so I do appreciate you taking the trip here. My name is Tiffany Lee. I am the director of the Addiction Studies program here at Western, housed in the College of Health and Human Services, and also under the School of Interdisciplinary Health Programs. Last year, I attended the WMed Addiction Conference and heard from our speakers. And I thought, wow, stuff is going on in the community that I was not aware of, in particular with behavioral health, medication for addiction treatment. And I said, how great would it be to share this information? And so some of you may know Pam Wadsworth from nursing. And so she is connected with WMed, street medicine. And so I asked, hey, do you think they can come in and speak? So this year at the Addiction Conference, I cornered Dr. Helmstetter here, and I said, will you please speak with us? He couldn't say no, so we're here today. So I appreciate all of them coming and speaking. If you're not familiar with the WMed Addiction Conference, it is in November. It's great. They have great speakers, great content. You get CEs for it, so I'm kind of plugging the conference there, and it does happen in November. So consider joining them over at the School of Medicine there. What else? About 60% of you have heard of WMed Street Medicine, so I'm glad that you are here to learn more. And for the 40% that haven't heard from street medicine, I'm glad that you're here because, like me, I wasn't aware of what was going on. And in particular, again, behavioral health and MAT. So a couple things. If you are a student, please make sure that you have signed the sign-in sheet if you're here for extra credit. And also if, what's the other thing? Oh, we are getting recorded today. It's not live, but if you are interested in getting a copy, you can email me and I will send you the link. You can share with whomever. And in particular, if you are an instructor and want it for your students. And so we will embed this within our addiction studies curriculum as well. So hello to all online. I think with that, I will do some introductions. And so I will start with the director. Dr. Shravani Alluri is a family physician. She is a graduate of Mapal University and the School of Medicine in India and completed her residency in family medicine at Western Michigan University Home Stryker School of Medicine. From 2016 to 2017, she completed a research fellowship in disaster medicine at Harvard Medical School. Dr. Alluri was awarded the 2021 Michigan Family Medicine Resident of the Year for her work in the Kalamazoo's unhoused community. She is currently an assistant professor at the Department of Family and Community Medicine at WMed and continues to work at Street Medicine, Kalamazoo. Dr. Nick Helmstetter is a dual-boarded pediatrician and internist for Meds-Peds. He is a graduate of Kalamazoo College. He earned his medical degree from Wayne State University School of Medicine in Detroit. He completed his combined Med-Peds 4-year residency training program at Michigan Medicine in Ann Arbor before joining the Med-Peds faculty at WMed. His clinical interests include office and hospital-based procedures with ultrasound guidance, Nexplanon placement, say that 3 times fast, treatment for SUDs, caring for adolescents and young adults with special healthcare needs, and prescribing PrEP. He completed LGBTQ+ competency training via outcarehealth.org and is an OutCare member. He rounds on hospitalized adults in both Beacon, Kalamazoo, and Bronson Methodist hospitals and his WMed resident physician teams. He's been practicing street medicine as the associate director for WMed Street Medicine Kalamazoo since 2021. And then also we have Luca Mitchell, who is the peer recovery coach for Street Medicine Kalamazoo. And they are involved in community care and works diligently in peer recovery, creating lasting relationships with their unhoused residents. They are a longtime resident of Kalamazoo, and in their leisure time, they like to crochet, practice guitar, and dance around their living room with their cat. So with that, I will hand it over to Dr. Helmstetter to begin. Okay, Brian, maybe you don't need
It's so complicated. There's so many microphones and screens. I'm Nick, the Associate Director of Street Medicine Kalamazoo. We're here to give you an overview of what street medicine is internationally, what it looks like locally, and then hopefully spending most of our time talking about substance use disorder and how we address it. So street medicine overall is an international movement to bring healthcare directly to people living outdoors. I'm glad that so many of you have heard of it. Directly outdoors where they're at. It started with Dr. Jim Withers. He first coined the concept of street medicine in the 1980s and founded the Street Medicine Institute, an international organization that aims to advance street medicine as a distinct healthcare discipline specialty. In 1985, jumped a little bit, sorry. In 1985, Dr. Jim O'Connell began his full-time clinical work with unhoused individuals as the founding physician over in Boston's Healthcare for the Homeless program. He established the nation's first medical respite program in 1985 with 25 beds. Soon after, Dr. Philip Brickner in New York City used the street medicine approach to create healthcare for the homeless model of care in the mid-1980s as well. Today, Street Medicine Institute estimates about 50 independent street medicine programs operating across the country, and there's many more internationally. And they're funded by a variety of ways. Many are run by volunteers or students. Some are independent nonprofits, while others are operated by hospitals. Many of the about 300 healthcare for the homeless programs provide street medicine specifically. So what do we do? So in a nutshell, we take everything that can be done inside, outside. As Dr. O'Leary shared with me, some of our patients say we bring the whole hospital to them, and that's really the goal. So we want to serve as a medical home for the unhoused. Currently, care provided to the unhoused population can be very disconnected and disjointed. They may get some care at hospitals, in the ER, occasional clinic visits with different clinics under different healthcare organizations around town, but nothing consistent. We're trying to provide consistent care as this is the only thing that can affect clinical outcomes. And it's a model of care that goes out to patients and provides care and navigation on site. Has been increasingly shown to be more effective in providing care not only to this patient population, but other high-risk populations as well, as there tends to be crossover. The reality is that health in the unhoused is a crisis. It's not just a housing crisis, but a health crisis as well, and they're interlinked. All patients die from diseases that are housed. Our patients die from diseases that are housed counterparts will most likely survive. We wanted to share these photos, they're all publicly available, of individuals that we know or have known. Many see homeless individuals as a problem, but there is community, and each of them has touched our lives in different ways with their humor, their kindness, and their stories, and we realize it's a privilege to care for such a vulnerable and marginalized patient population. All right, with that, I'll transition to Dr. O'Leary, talk more about street medicine, how she built it, where we're at today.
Sorry, I'm like trying not to make too many microphone noises, but let me get this hooked up.
While she's getting hooked up, how many and how many are from the community?
Awesome. Awesome. So my name's Shravani Alluri. I direct street medicine and started the program in 2021, January of 2021 now, and it's surprising how long it's been and how much progress we've made in the 5 years. So that's just briefly what I'm going to talk about, how street medicine started. And we started because one of the things that I was noticing when I was a resident in family medicine was that a lot of our admissions in the hospital for people that kept coming over and over again, they're individuals that were unhoused. And no matter what we tried, like to get them into clinics so they could get care outside of the hospital as well, we weren't really successful with it. I gave people flexible appointments. I was like, anytime between 8 and 5 while I'm there, you can show up and I will see you. You do not have to come at a specific time, but it was still like 25% of the people that I scheduled like that actually came in. So I was like, we need to do something different, and then heard about street medicine from one of the conferences. There's the street medicine conference, and I was like, this is cool. I like home visits, and that's essentially what street medicine is. It is home visits for unhoused individuals. But we started off really simple. That's my Jeep over there in the corner. But my Jeep used to be our clinic. Like we'd see patients in the back of my Jeep, and that's how we carried all of our supplies. And then we kind of grew to figuring out how do we take a clinic out to people without creating too much of a sterile clinical environment. And toolkits are what work. We use Milwaukee's right now, and that's how we take all of our testing supplies. So we draw labs on patients. We give them injections if they need anything. We do procedures, like if there are infections or abscesses or they have like a scary skin lesion that we're worried about, we'll do that all on the field. So we take all of that out with us, and even some diagnostic testing, like ultrasounds, both of us do ultrasound, so we take that out and use it to help us with making diagnoses on the field. And the other big thing, this picture at the bottom that's outside the PFC. And when we started in like 2021 and even in 2022, it was always, we started off, the first thing that I did was spoke to all the community organizations that worked with the unhoused. Like Kalamazoo Harm Reduction was a big one that I initially partnered with and they're our syringe access program. You'll hear about them a little bit later. But I partnered with them to go out because they were seeing a lot of medical needs and people that didn't want to go into the ED to get taken care of because they haven't been treated well there in the past. So they'd rather kind of take care of themselves than go in. So I learned a lot from organizations like that, like ISK, the police department, like all the different our health organizations as well, because we're a part of them. So, and we'd go out kind of with a collection of resources. So it was always medical care as well as meeting other immediate needs, which is essential to street medicine. Like you can't go like, let's take care of your blood pressure when someone's like, I need to find a tent for tonight, or like, I don't have shoes right now. So we, like that setup, there is actually someone there that's handing out food, some warm food in the fall. There are people giving out clothes as well. We often try to meet some of those extra needs. So we're meeting people's priorities and making sure they're getting what they need in addition to the medical care. So that's A little bit. So we work in collaboration with a lot of organizations. And today, over the years, we've funded street medicine through different grants and philanthropic donations from organizations in Kalamazoo. But it's helped us kind of expand to having a mobile clinic. And this is our patients, some of them really love the mobile clinic. They're like, they bring out a hospital to us where we are. So it's really helped us provide private care, provide more, it's much easier to do things like pelvic exams in a mobile clinic than in a tent. We've done both. But different things like that, we're able to get cancer screening and stuff done a little bit better using the mobile clinic than if we have to kind of figure out how we're going to do it in the tent. But we've always done both. And even now, even though we have our mobile clinic, we still go out to see patients wherever they are as well, because not everyone is comfortable coming into the sterile environment of a clinic. So maintaining that and being able to go out to encampments still and taking care of people where they feel most comfortable is still a big part of our program. This is I think this is our entire team except our pharmacist and nurse aren't there. But we've grown from just me going out to camps to adding Dr. Helmstetter, and now we have our peer support, Luca, who you guys will hear from, a social worker, another nurse practitioner, and a coordinator, as well as part-time pharmacist, a nurse manager, and Pam, who you guys may know. So Pam provides women's health care as well as pregnancy-related care. To our patients as well as some of our clinic-based patients as well. So it really, all of this has been, we've kind of built the program over the last 5 years, with piecing together its support through different grant applications and supporting different initiatives that were important to our patients. So one of the things, the way that we have grown has often been it's really influenced by the needs that we were seeing, the needs that people were talking about. Our patients have been a big part of how we design our program and the services that we provide. So Dr. Helmstetter mentioned we're a primary care clinic, a full spectrum primary care, so everything that you go to your family doc for, we do that. And more, we draw our own labs, do our own testing as well on people. And we do specialty care as well. So a lot of primary care offices don't always do addiction medicine. So both Dr. Helmstetter and I are addiction medicine board eligible, and we do a lot of, anyone that's interested in treatment for substance use disorder, we will treat them with medication. So using naltrexone for alcohol use, using buprenorphine for opioid use, and we can't do methadone for opioid use because you still have to be a treatment center to do that. But at least buprenorphine has been a great resource. So doing long-acting injectables with the buprenorphine. They have the monthly shots now, which has been really great for some of our patients. We also treat stimulant use disorder with our contingency management program, which you guys will hear about, as well as some of the medications that can decrease cravings and stuff in stimulant use. And Dr. Helmstetter mentioned that we provide continuous care. So what that means, the one big thing that we noticed when we looked at all of our data around what kind of care were our patients getting. So either there were a lot of individuals that did not interact with the healthcare system at all. And there are a lot of individuals that interacted with the healthcare system a lot, like they went to the ED all the time, or they'd have random clinic visits at family health centers, sometimes at WMed or Bronson, but never anything continuous. And our patients we see so many individuals, we kind of prioritize seeing individuals that are more medically complicated. And that sort of random care or using the emergency department for care does not help chronic medical conditions. You need someone who's able to piece everything together, take care of them continuously and over time. So that is what we provide, continuity, not just random once in a while care. And we follow our patients everywhere. Dr. Helmstetter and I both round at the hospitals. I am only at Bronson. He's at both Bronson and Beacon. So when patients need to come into the hospital, they're getting admitted to our teams. So there's that communication of like, this is what's been going on outside the hospital with the patient. And it helps coordinate their care, and then they know us. Like there's that piece of trust, and like the fact that they have a relationship with our team helps quite a bit with making sure that they get the care that they need. And we also work with the county jail, kind of informally, but our patients are in and out of the in and out of jail quite a bit, but we treat them while they're in jail, get them their medications, get them some testing once in a while they're incarcerated as well. It's been great. Like we treated one of our patients is like quite a few. Did we treat more than one for Hep C while they're in jail? Because that's 8 weeks of a pill every day. So it was like kind of a good opportunity, and they're free of Hep C afterwards. So, and we've started them on like treatment for substance use disorder sometimes while they're incarcerated as well. The other big thing that we do is that what's also central to our program, being based out of WMed and being academic, like education, not just for physicians and resident physicians and medical students, but we have social work students that come out. We have a social work intern right now, nursing students that come out. We've had pharmacy students, so anyone, and college students that are pre-medical. So anyone that's kind of interested, we try to get them out and so they can learn more and participate in the care as well. I told you guys about our team already, and these are just kind of our numbers to give you an idea of. So over the last 5 years, we've taken care of over 500 individuals that are unhoused in Kalamazoo, and that just keeps growing, the total number of people that we've taken care of. On a weekly basis, we see about 40 people between the two main days that we're active, and then we also see people as needed on other days of the week as well. And we have a lot of different programs. Like we focused in on Hep C because it's the rate of Hep C in our patient population is very high. And we, funded and kind of have a Hep C treatment program where we do supervised treatment with patients. We funded, gotten opioid mini grant funds for getting Suboxone, buprenorphine out easier to patients. So we have supplies on site sometimes and can start someone on treatment immediately if they would like to. Out of those funds now, have to refresh and get more. But with that, we had like 58 individuals of our 500 that are on treatment for opioid use disorder with us. And what also kind of speaks to the continuity of our program, 60% of those individuals continue to follow with us over 6 months. And if you know anything about kind of substance use programs and clinics, that drop-off rate is actually really high. A lot of times you're lucky if 40% of your population follows with you. And then at a year, those numbers drop down even more to like 10% or less. But we've maintained like 60% of our substance use disorder patients At a year, I think we were at, I don't want to tell you the wrong number, but higher than national averages overall. And that's just because of the model of care, of like going out to people, of focusing on the relationship, and of this being like really relationship-based care, and building trust with people. So even if we lose someone for a little while, they usually come back and find us at some point in time. A lot of research, a lot of talks and presentations. So if you all are interested in doing any work like that, we're always excited to have you as well. Hand it back over.
And we do pride ourselves in being multidisciplinary and having learners. That's our aim. We even have one of our medical students with us today that's doing a sub-internship. Musa, will you say hello? He's going to be a surgeon. So we talked a bit about like how we treat such disorders, and there's other options in town as well. Family Health Center, for one, should be aware of. WMed itself, we have a brick and mortar addiction medicine clinic out of the WMed Crosstown Family Medicine Clinic too, with Dr. Maureen Ford. So more and more options, plenty of access. So we alluded to all this earlier, like why we're treating, but here are the stats. People experiencing homelessness are sicker and die sooner than you and I. And you all in a program know that the death from drug overdose is more than a factor of 10 in people experiencing homelessness. And then overall, 1 in 4 deaths are specifically due to drug overdose. So the work that you're doing as well in this program is very important, especially to our patients, and we thank you. So speaking about our area, our patient population more specifically, just can touch on our substances and adulterants. We're lucky to have their forensic fluid lab in town. They serve like a tri-state area, a lot of times court systems, adult protective services, child protective services, hospitals use them, clinics use them as well. And what's nice is it's not a urine drug screen where there are plenty of false positives, false negatives. It's saliva that's tested with mass spec, and so you get very accurate results down to nanograms per milliliter concentrations reflective of what's in saliva, what's in your bloodstream. So out of our samples, 75% included methamphetamine, and it's common enough that based on our experiences, we were able to contribute to an article in the New York Times back in November of 2023. If you're going to try and find it, you can Google a monster, super meth, and other drugs push crisis past opioids. So 3 out of 4 of our forensic fluid lab samples include meth. And our drug supply as well, whether it be fentanyl or meth, has been contaminated just like other places nationally with xylazine and medetomidine as well. And as most of you probably know, our heroin is fentanyl, and our meth has fentanyl in it as well as other stimulants. And polysubstance use, whether it's a use disorder and which substances will qualify them for use disorder and which they're using without a use disorder, it's a mixed bag. So polysubstance use is very common. Most of our patients use more than one substance. Fairly ubiquitously, our patients will be using nicotine and THC as well, and maybe in the setting of their methamphetamines or their opioids. So taking a history is important, and prioritizing is important as well. With that, I'd like to hand things off to Luca, our harm reductionist, peer support specialist, and recovery coach, our newest and most important team member. However, this work is not new to them.
Hi, can you, hello, hello? I turned it back on though. Oh yeah, okay. Can you hear me? Give me a thumbs up. Perfect, thank you. So my name is Luca. As they said, I am our peer recovery coach and sports specialist at Street Medicine Kalamazoo. I used to work at Kalamazoo Harm Reduction, my bad. So we're gonna go, oh, you already switched it, okay. So what is harm reduction? I'm gonna ask you. Shout out and answer, raise your hand. What do you guys think harm reduction is? Meeting people where they're at, that is totally an aspect of it, thank you. Anyone else? So it's essentially a series of public health choices and practices that aim to reduce the harm associated with using drugs. The harm reduction movement in the United States started in the late 80s, early 90s in response to the AIDS crisis. People were handing out free syringes and condoms. It was primarily started by Black and brown individuals as a mutual aid effort. When it first started, it was a one-to-one exchange. So for every syringe you gave back, you would get one, a fresh needle to use, essentially. That model has since been mostly discontinued by a lot of places because not everyone is going to have syringes to give back. If you're moving sites often, or you're unsure of where you're sleeping, you might not have all the syringes that you use. So let's say you had 10 syringes and you only give back 5. Well, you're using all 10 syringes, so it doesn't really make sense to only give them 5, right? So the idea of a one-to-one is called a syringe exchange. However, we call it a syringe access program. We try to give people as many supplies as they need to fit their use without having to limit the reuse of any needles. So that's kind of like how harm reduction was started. Another point that I think is really important to talk about in this is the language around people who use substances. Oftentimes in popular culture, we'll hear people say, "I'm clean," or things like that. Words like clean and dirty, when you're talking about people who have a substance use, is a moral implication that is unnecessary when talking or communicating with them or treating with them. We often like to use words like people who are in active addiction, or people who are in recovery, or all of these languages in between, right? But we really want to try to take away any sort of moral implication when talking to them or about them. I do think it's important that we let people who are in active use or in recovery to some extent talk about themselves the way that they want to talk about it. Just like other marginalized groups will refer to themselves and in their community as they do, but as people who treat them or talk to them or support them, the language that we use is really, really important. I think a way that I like to think about it is, if it sounds like a slur coming out of your mouth, do not use it. I think that's pretty simple, right? Okay, so another question is, what do you think harm reduction is? Like, what are some practical applications of harm reduction? You can raise your hand, you can shout it out. Okay, so any change is a positive change. Yeah, absolutely, absolutely. That can be a form of harm reduction. I know that in popular culture, people like to talk about how like seatbelts are harm reduction. And that is a great entry point to understanding the principles of it, where it's a decision that you're making that will impact your body or how you interact with the community in a positive way. But I think that it is really important for us to understand and recognize that harm reduction in itself is about substance use and practical health like applications, if that makes sense. If you have questions about that, there will be a Q&A. We're going to move on. So I am a peer support specialist and a recovery coach. Essentially what that means is that these are state certifications. There's some kind of national certification, I'm unsure. But it's people who have lived experience with substance use and or mental health that go and support people who are also experiencing this, right? Because I don't know how many of you, struggle with your mental health, but talking to a physician, a family member, or trying to seek help for these things and talking with someone who has an academic or a theoretical sense of what you're going through, but the lived experience is not there, is sometimes there's a big barrier, right, in trying to communicate with them how you're feeling. It's sympathy versus empathy, right? When you've experienced it, you can empathize more, versus if you have like a technical knowledge, it's like more sympathizing, which is great, and it's not to discount that, but when you're dealing and talking with a population that has been so harmed by systems, that having people who can talk to them in their own language that understand what they've been through is so important. Yeah. Any questions about that? Cool. So, that's the wrong, oh, I held it wrong. Okay. So I'm going to go over some of the safe supply use that we get, that Kalamazoo Harm Reduction, which is a program of COPE Network. It's Kalamazoo County's syringe access program, give out. So these are syringes. They are subcutaneous insulin syringes. There are two different kinds that are generally given out nationwide. These are shorts, so they're a 30 gauge 5/16 needle. It's a full cc. And then longs is a 28 gauge half-inch needle, also a full cc. Most people will use shorts. That's like, when I worked at Kalamazoo Harm Reduction, I would say 95% of the syringes that we gave out were shorts. And that's for a variety of different reasons. But people also use longs either when the weather changes, or if they're having to access different veins and stuff like that. We try to give them an option, so that, because people's bodies are different, either just by being different or through long time use. There's a lot of different things. So we wanted to at least offer something that was not just one type of syringe for them to use. In addition, they give out alcohol pads. We try to give out at least one alcohol pad for one syringe that is given out, so that every time that they use a needle, they can clean the site on their arm or wherever to, try to at least eliminate some bacteria coming in. This is a gauze pad. We give them a tourniquet, Band-Aids, some sterile water. These are, I don't know how well you can see it, but it's essentially like a little tin circular cooker. It's probably about this big. Some substances need to have heat added to them to break them down to make them a liquid, to pull it up into your syringe. And you can get burns on your hands. So we give them these zip ties, to twist ties to go around so they can hold it, essentially, to try to eliminate all kinds of harm that comes with substance use, even if it's just, your little fingies are burned a little bit. And then in addition, this is a syringe container. We give out syringe containers because, a lot of people don't want to see used needles in the community. There's a lot of risk associated with that. So to promote getting the syringes back, we give this out. They can give it to us loose, or we prefer to give them in a container. So us or Kalamazoo Harm Reduction or all of the other places where you can dispose of your needles, even in, I'm sure the bathrooms here have little syringe things that you can just put your needle in and then it goes down, and they all get taken for proper disposal. So this is just promoting that. In addition, there are, intravenous is only just one way to use. There is also smoking, which is not less harmful, but there's less risk of spreading bloodborne or other communicable diseases when you smoke your substances rather than inject them. So this right here is a bubble. It is primarily used for meth. There's a straight pipe that's just the line. It's essentially this, just the pipe, no bubble. That's primarily used for crack. But they also give out both straight pipes and bubbles for use. And I would say that the bubbles are probably one of the most used products that are given out, right? We have a lot of patients who have transitioned from using intravenously to smoking, and through their own decisions and all of these things, and have reported, having less long-term health use, chronic health issues due to that use. And lastly, the thing that I want to talk about on this slide is test strips. Dr. Helmstetter touched on this a little bit, and if you read the news at all, you will know that there is a lot of talk about fentanyl in all of our supply, right? Like some of it I think is a bit exaggerated, like you're not always finding fentanyl in weed, especially in Michigan and stuff like that. However, the cross-contamination of drugs is real. Are a lot of drug dealers, people who sell drugs, are not just selling one product anymore. You have to diversify, right? Especially as people are using more and more. I mean, if you want to make money or whatever you need to do, you can't just always sell one thing, as we can see with our polysubstance use. People are using a lot of different things. And so some of it is cross-contamination between, packaging up heroin and then going to your meth. You don't necessarily clean your surface properly. It gets in there, right? Whether it's intentional or unintentional, the end result is that they're seeing fentanyl in stimulants and other substances that aren't opioids, right? So these are test strips that we try to give out as often as possible to let the people who are using substances have all of the information to make the most informed decision about themselves and their body and what they're doing. So Rapid Response is a really popular testing company, test strip company. They say that they can pick up 0.01%, like if there's 0.01% of fentanyl in the substance, like the sample that you're testing, that it will show that it will have fentanyl in it. It's a pretty quick turnover. It's maybe like 2 to 5 minutes. They also have xylazine and medetomidine strips. Xylazine is becoming, and medetomidine are both sedatives that are becoming more and more prevalent in our supply here, but especially on the East Coast right now. Kensington and Philadelphia is seeing a lot of medetomidine, a lot of xylazine, and one thing that is kind of scary about that is that because it's a sedative, Narcan doesn't work. So we have used Narcan as the gold standard or naloxone. Narcan is the brand name or whatever, but naloxone is the gold standard to reverse an overdose in a lot of places. But if you think that someone is overdosing and the Narcan isn't working, like what are you going to do, right? We don't know. But well, actually we do know. CPR, yeah, mostly just rescue breathing, honestly. But in that moment, if you come across someone and you're like, what is happening? And you give them Narcan and they're not responsive, like there's just a lot of things that in the supply, because the supply is so up and down and they're introducing new things all the time, these are things that people who use drugs really have to think about and try to, be aware of as much as they can. So the last thing I'm going to talk about is our contingency management program. So a contingency management program is essentially having your patients in a program where they are essentially talking to you about their substance use, and there's some metrics to meet, right? We're trying to meet with them weekly. We're trying to have them drug test weekly and stuff like that. But a key part of it is that in those, they set their own goals. They set whatever they want to talk about, right? I think it's really important to tell them that recovery is not the goal if that's not their goal, right? We just want to be supportive and have an open conversation and understand what they're doing with their body, how they want to change what they're doing with their body, and how we can help them. I know that Victory Clinic, our methadone clinic here, also has like a contingency management program. They have some different stipulations than we do. I think it's like a 6-month-long program that you can only be in for up to 18 months, or you can't, once you do it, you can't re-enter and things like that. We want to offer an incredibly low barrier, right? So we want to essentially reward people for meeting their goals and meeting these metrics with us. So like just for coming in and talking with me and drug testing, they get like a $5 gift certificate, gift card thing to Speedway, right? Just for coming, because we really appreciate that. And it gives us the chance to talk and like see what's going on with them. And if they test negative for the substance that they identified that they want to like test negative for, we give them another one, another $5 card, because I think that so often people get into these things where it's like they're not seeing any progress, they're not getting any positive feedback, or they're getting negative responses because they can't stop testing positive for the substance. And it's really hard, man. It's really hard, and we want to reward all of these actions as much as possible. Cool. I'm going to hand it back over to Dr. Nick. Thank you.
So I think the take home would be that this work is important. It's a big spectrum. Folks in SPADA are part of that spectrum. And it takes a big team. And the work is important because people are dying. And if you're not doing work like this, you're giving people a death sentence, as we saw from some of the previous slides. And with that, we left enough time to leave it open to some Q&A, and we have some prompts if there's crickets.
Well, while you're on that slide, actually,
Sure.
Dr. Nick, I didn't see Narcan or naloxone on there. Is
Yeah.
that something that you've given the kids for harm reduction purposes?
Yes.
And it is around town as well. There's like dispensers that are like where you used to get a newspaper when there used to be newspapers. There's one in front of our clinic. There's one on Kay's campus. There's one down at Ministry with Community, one of the day and now night shelters for the unhoused. So absolutely part. You in the back.
Vincent.
Vincent.
I have two questions. First question is, how do you intersect with mental health treatment? I don't think you have a psychiatrist on the team, but you must encounter serious mental health issues all the time. So how exactly do you intersect with, say, mental hospital?
Yeah.
The second question is about funding. I am aware, for example, that in July, Trump signed an executive order yanking funding for harm reduction. And Medicaid is going to be transformed with work requirement. I think this will happen in December this year. So how exactly does this type of federal involvement impact your funding?
So Vincent had two questions. One is about the intersection of substance use disorder, mental health, and obviously not having housing affects both of those things. And the second question is about funding or support in this political climate. I can speak to the mental health part, and then since Shravani runs the program, more of the day-to-day funding grants, I'll let her speak to that part. It was a specific part of like our board certification application where you have to show competency in your hours, which we both derive pretty much uniformly from street medicine, a little bit from our work in an actual clinic or in the hospital, about mental health as well. And people use substances for all different reasons. Can be a chicken or an egg. It can be circuitous. It can be a catch-22. And certainly ACEs, adverse childhood events, toxic stress, other traumas, PTSD, not having access to mental health treatment or overall, general treatment can drive mental illness. And certainly there's genetic components as well, nature, nurture. So you can't ignore those mental health diagnoses as well, and we diagnose them together, and it's often hard to tease them out, so we treat both. A lot of our patients that have low mental health, whether it be major depressive disorder, generalized anxiety, post-traumatic stress disorder, complex post-traumatic stress disorder, bipolar disorders 1, 2, schizophrenia, schizophreniform, schizoaffective disorder. We're primary care doctors. You don't need a psychiatrist to treat all that stuff, and frankly, there's not enough access to psychiatry. Bona fide physicians that have trained long and can handle complex mental health conditions. That is important. There are street psychiatry teams. We do coordinate with WMed psychiatry if we have a question. It doesn't come up a lot. We're very comfortable diagnosing and treating complex medical conditions, psychiatric among them. For folks just like we have for opioid use disorder, long-acting injectable medications, buprenorphine, for our patients with psychotic features, psychosis, marginally safe to take care of themselves and remain in the community, we don't hesitate to start long-acting antipsychotic medications as well. And when they become unsafe, we don't hesitate to petition insert them and get them the help they need and coordinate that care in the hospital along with our psychiatry colleagues. Does that answer your question? Cool. Thanks, Vincent.
I'll speak to the funding piece because I'm working on it right now. And figuring out how are we going to fund our program over the next year and afterwards, right? So with the harm reduction funding being cut, we're still waiting to see. I know the state's budget came out recently, so we are still waiting to see what it's going to look like and how much of the opioid remediation funds will be released to be able to cover some of the cuts that are happening for like the harm reduction funds because of the because of the current government. The other thing, like for street medicine itself, like there are actually still a lot of, there have been more opportunities for healthcare for the unhoused. Like they're still like releasing funding, federal funding related to that. Even though it's like they had budgeted a larger amount with the previous administration and the total budget has decreased for it, but they're still prioritizing kind of low barrier care or access to like care for underserved populations. So it's still somehow fitting with the current administration's agenda. So street medicine overall or care for some underserved populations is still being prioritized. So there are quite a few of those grants that we've been looking at as far as like federal or state funding. The other thing is like getting creative. So where is the funding right now? Kind of in defense and justice. So we've been looking at DOJ grants to fund some of our, like our addiction medicine fellowship program that WMed is working on, which we'd be a big part of as well. So kind of following where the funding is going in some ways and getting creative with how we apply for it. One of the good things, like Kalamazoo has a really good philanthropic community between like the different companies here, like Stryker and Pfizer, no, more so Stryker. But the foundations have like increased support specifically for healthcare services. And have actually reached out going like, do you need funding? Which has been, helpful. So that's the other thing that'll probably bridge us over the next few years. These programs though, like they don't always, I don't think like 5 years down the line, we're gonna be dependent on philanthropic funding or grant funding. I think for some pieces of it, yes, but this Medicaid is reimbursing for the care that we provide. So when we go out and see patients don't end up with a bill. Like we don't give them a copay, or if they're uninsured, we don't charge them. But when they have insurance, when they have Medicaid, we do get reimbursed for the visits as well. And for different services like peer recovery is reimbursable. Counseling services, like all of that is technically reimbursable. It won't give you all the money you need, but it helps get there. So we're looking at kind of the argument that I am trying to make and making slowly through data is like we looked at just 400 of our 500 patients, and they account for more than 10% of hospital admissions. And that's an incredible expense to the healthcare system. And when you're looking at like funding cuts overall, you have to figure out how, like we're always looking at how do we stretch our money as much as we can. And with them accounting for so many admissions and complicated, long admissions that cost the healthcare system a lot, there's also funding that needs to come from the hospital, the local health systems for these programs as well. So that's the other way that we're at least partially funded. Both. So if we don't see someone, we're starting to check the jail registers. And because we work in the electronic health record system, the ED visits will pop up pretty quickly. A lot of patients that follow with us very regularly, we will know when they go to the ED, or we've sent them there, and then we coordinate directly with the physicians there about why we've sent them in. So generally, like we'll know from the electronic health record, or they would have told us. The jail, it's variable. Sometimes like the nurses will reach out to us when they have a patient that's established with us and getting medications from us. They'll automatically reach out and go like, hey, we have this individual. Can you bring these like X medications over, get them delivered? And then when we can't find people, we're looking them up and seeing if they've been incarcerated perhaps, and then reaching out directly to the jail. Repeat the questions. Yeah, I can do that.
On that same note, if you're technically their primary care physician, in the electronic medical record, is Western Street Med listed as PCP? Is your name listed as PCP? So if the hospital system were need to do any sort of coordination at discharge, is that?
Yeah, so who's listed as PCP for their primary care provider? So WMed Street Medicine is listed as PCP sometimes, and the hospital is actually good at just like assigning us as PCP if someone is unhoused. So it is, we're there in the system. You'll be able to see, and our visits come up as street medicine as well. So if you're in the EHR, you'll be able to see that.
For the Hep C treatment that you were talking about earlier, do you guys require abstinence for them to be treated for that?
No, that's illegal now. So MDHHS changed, huh?
Repeat the question.
Oh, sorry, repeating the question. For Hep C treatment, abstinence required. Abstinence is not required, right? It's more like we try to ensure clean use, don't reuse needles, don't share. But the MDHHS passed the We Treat Hep C initiative in April of 2021, actually, where like abstinence can no longer be a requirement for Hep C treatment because there is a big lawsuit, actually. Someone sued because they didn't get treated or were denied treatment. Before, you couldn't get Mavra, you couldn't get any Hep C medications because insurance wouldn't authorize it if you were still using. So they had to prove 6 months of abstinence to get treated, which is not. We've treated between 30 and 40 patients, many of whom have remained free of Hep C and continue to use drugs.
I'm just going to take going back to that like harm reduction standpoint too, if someone is not using substances and then getting treatment for their Hep C, that's like, it's great for them, obviously, but they're most likely to give or spread Hep C if they're actively using. So it's like the ideology of abstinence only Hep C treatment is backwards.
It actually probably perpetuated the epidemic.
Yeah, oh, definitely.
Because you have a lot of untreated individuals in like one community. So it's a good policy change from a public health perspective. what else? There are some other hands.
How does your mobile clinic work? I mean, do you set up like on certain days at certain locations so the autopsy population knows where to be?
Battery dies.
Unless our battery dies, which it is dead right now. So our mobile clinic, we use it in a few ways right now, and this changes like every year or every 6 months, depending on where people are at or where the resources have moved. But we take it out on Mondays to the River Church right now. And kind of by word of mouth, our patients know how to find us there. And we also have answering service. Like we have our own phone number. So if they call that, the message tells them where we're at. And like most of them find a way to get in touch with us somehow. And like we will let them know that that's where we are Monday afternoons. It's on our website, and some of them have started Googling us and find it that way. So it is, that's generally how we're doing it. And a lot of it, we know, we started street medicine when the big camp was open, like on Mills and stuff, and there are like over 200 people in the camp. And at this point in time, a lot of people know us. So like a lot of the community, the unhoused community knows of our team, our services, and even I think like the way that we get most of our patients is word of mouth or people that know where we are bringing them to us as well.
How many of your patients are minors, and how do you
So how many of our patients are minors? I have had a few that are minors, not too many, because I've like responded once to someone that was in an abuse situation and out front, but it hasn't been a lot. I know that the need is there, but like we haven't really bridged into like providing all of those services. So the few instances where we've had minors, we've provided the care that they needed. So.
Just if I miss enough time, you can stay after if there's more questions, but I want to adhere to our 11 o'clock time. Thank you so much. And